Okay, welcome to my next session of videos. How to diagnose the deep vein thrombosis. The clinical presentation often non-specific. Number two, low predictive status. Low predictive value, like 15% only, 1.5. Symptoms, local swelling, discoloration of the legs, increased warmth over the skin, more visible surface area of the veins, cough or leg pain or tenderness. Classical human sign. What is that? Pain when dorsiflexion of the affected foot, which is often difficult to distinguish from the simple muscle strain, injury or skin infection. Lab studies, a positive D-dimer test has limited clinical value. Doppler ultrasonography, most commonly used test, but a normal result cannot rule out DVT. Contrast venography, considered as a gold standard test to diagnose the DVT. Others, like spiral computed tomography, impeded plethysmography, magnetic resonance imaging, that is MRI, pulmonary embolism. Clinical presentation. Clinical features are mild and non-specific. Diagnosis is difficult to establish on clinical presentations alone. Pre-operative and post-operative presentation of pulmonary embolism. Most consistent is the acute dyspnea, 75% of the cases. Tachypnea, 70% of the cases. Observable with PE, pulmonary embolism, near the pleural surface. So what are observed? Pleuritic or chest pain, that is 60%. Rales, 50%. Cough, 40%. Others, possible wheezing on auscultation. Wide S2 splitting, tachycardia. Intraoperative presentation of pulmonary embolism, often transient and non-specific, include the sudden onset of the following symptoms: hypoxemia, low EtCO2, bronchospasm, high airway pressure. Now I come to the lab studies. Normal D-dimer test has a higher negative predictive value of up to 99.6%. ECGs could be normal, but findings listed are not specific. or sensitive, like STT wave changes, peaked P wave, then RV strain, right one branch block, RBB, and S wave in lead 1 and a Q wave and T wave inversion in lead 3. S1, Q3, T3. In up to 70% of patients with PE and no pre-existing cardiovascular disease. Chest X-ray is often normal and arterial blood gas ABG may show respiratory alkalosis, hypoxemia and increased AAGD, that is alveolar arterial gradient. VQ scan, ventilation perfusion scan, used to be first line of study but has been associated with high false positive results of up to 50%. A negative scan is of high value and can essentially rule out the PE. Currently, the test is reserved for patients with major renal impairment, anaphylaxis to intravenous contrast, or pregnancy. High resolution CT scan. Currently, standard diagnostic imaging test to evaluate a suspected pulmonary embolism. Sensitivity and specificity nearly 90% for main and robot embolism. Negative predictive values up to 99.1%. Pulmonary angiography, gold standard test to diagnose pulmonary embolism, used when other imaging modalities are non-diagnostic or contraindicated, and a higher clinical suspicion for PE persists with hemodynamic instability. Transesophageal echocardiogram may show acute dilation of right atrium and right ventricle. Treatment. The primary objective treatment of VTE are to prevent and or treat the following complications. Prevent further clot extension. Prevention of acute PE. Reducing the risk of recurrent thrombosis. Treatment of massive ileofemoral thrombosis with acute lower limb ischemia and or venous gangrene. Limiting the development of late complications such as post-thrombotic syndrome, chronic venous insufficiency, and chronic thromboembolic pulmonary hypertension. Deep vein thrombosis. supportive care, limb elevation, local warming blanket, graded elastic compression, stocking with minimal activity for at least several days. Anticoagulation, heparin followed by warfarin at least 6 to 12 weeks. Pulmonary embolism, anticoagulation, intravenous unfractionated heparin, bolus followed by continuous infusion to titrate the prothrombin time to 2 to 3 times. The upper limit around 60 to 80 seconds is the mainstream therapy. Patients with stable vital signs, normal BP and no evidence of RV, right ventricular dysfunction, generally responded well with anticoagulation and other supportive measures such as supplemental oxygen. Low molecular weight heparin such as enoxaparin can also be used and are as safe and effective as the unfractionated heparin. Well, we come to the end of this session. Next session would be coming in the next videos. Thank you.